Hi guys, welcome back. And you had just the pharmacology session, and let's get into Obs and Gyne. I'm so happy to see the questions. I'm sure all of you got all of them correct. That's the fun of knowing gynecology. If you read the basics, these kind of questions you'll always answer in your sleep. I'm very sure, but I hope you've not marked the easy ones wrong. That is the always my request, because in a hurry sometimes you know the answer but you mark the wrong choice because you were just too excited to know the right answer. I hope that is not the case in your exam answering. Right, so we'll get into the discussions here, and I'm going to start with the questions which have been recalled by all of you. I'm sure that some of them might not be having the right kind of recall. Let's get into it now. So the recommended timing for postpartum intrauterine contraceptive device, PPIUCD. Now this is most appropriately called post placental. Please, it is always post placental and not postpartum always. Please remember, postpartum IUCD can also be the one which is put after the 6 weeks. So it is always given the exam as post placental. So since it's a recall, I know that the question might not be recalled properly. It is post placental. It's a hot shot topic, guys. I hope you guys are reading it properly. All those INICET students, I'm sure, NEET PG students and the MCA students especially, please read this. It is always coming in the exams. Okay, so post placental IUCD, the recommended timing, you know what you have to do? You're doing a control cord traction, you're taking out the cord. Moment to take out the placenta, throw in an IUCD. That's all what you have to do. Now, literally don't throw the IUCD, use a sponge holder and place it inside. So even in a cesarean, you can do the same. So post placental IUCD, mostly we do it within the first 10 minutes. You can do it up to the next 48 hours. Do not do it after the 48 hours, because now the chances of infection, the uterus is still open, and the vagina is a passage where there'll be a lot of bacteria. And if you handle, now you do a procedure in a uterus which is open and the vagina which is open, and there's a scar where the placenta was attached. So then you're going to invite a lot of infections. So 48 hours to 6 weeks, if you do, you're going to cause infections. Best time is in the first 10 minutes. You can do it up to first 48 hours. So yes guys, I'm sure you got this one correct. Within 10 minutes of the placental delivery, that's the best answer for this one. I'm sure all of you got it right. Right, next one is I think you want to ask me some questions on this. I don't think so. This is a, I'm sure you guys know it very well. Chalo, आगे बढ़ते हैं. So next question, a 20-week pregnant woman presents with mild bleeding per vaginum and is diagnosed with placenta previa. What is the next step in management? Guys, I'm so happy that I've taught you this so many times. Placenta previa, first episode, the bleeding will stop. 90% cases it will stop. So yes, placenta previa is bleeding, give a rest, give a sedation. Definitely 2 large bore IV cannulas, 14 gauge or 16 gauge, give her IV fluids, arrange for blood, make a good noise about it. Placenta previa is bleeding is the biggest emergency we obstetricians get. Yes, we make a lot of noise even otherwise. So make a lot of noise, get all your friends, make sure that you have the help to resuscitate the patient. But remember, most of the times the bleeding will stop, and that is precisely what is the McAfee-Johnson regime. So yes, do not think of operating the patient now. No, you don't have to, because the expected or conservative management will stop the bleeding. It stops bleeding in 90% of cases. That is what is the McAfee and Johnson regime. Remember, in one exam around 4 years back, they asked you what is the contribution of McAfee and Johnson in the in obstetrics. Yes, they asked you, and they are the pioneers of giving rest and sedation and waiting and watching, and patients will stop the bleeding most of the times. Now remember, the question which is actually coming in your exam is, what is the contraindication? This is also come. When will you not do conservative management? Yes, remember one thing, plaster previa which is bleeding, you will do conservative management. It is effective in 90% of cases, but you do an ultrasound and see the baby is dead. What are you going to conserve now for? You're going to do a delivery and a cesarean. That's why even you can do. Answer to this question is correct. We have heard the answer is this one. Yes, this is the answer. Don't get confused. But I'm saying, if you're doing a conservative management and the baby is dead, there's no point doing the conservative management anymore. Or the baby is having a severe anomaly like an anencephaly, or the woman is bleeding excessively, then so all these cases you will not do the conservative management. And the last one is the most important. If the patient is in labor, Please, if the patient is in labor with a plaster previa, again it's a contraindication for conservative management. These four, remember one thing, okay? Dead baby, anomalous baby, mother bleeding, and the patient is in labor. Do not give tocolysis in a bleeding placenta previa. She'll bleed more. So please remember these contraindication for the conservative management. Right, guys? Let's move on to the next one. And the question of the day, guys. Question number 3. A 30-year-old woman has postpartum hemorrhage not controlled with uterine massage and uterotonics. What is the next step? Wait. This question is better read this way. Wait a minute. I'll change the format. This question is better read this way. Look, 30-year-old woman, postpartum hemorrhage, not controlled with uterine massage. You have done uterine massage, and if then it doesn't work, you have to do the next thing. Uterine massage you have to do. If you still have a doubt, look, INICET, every exam one question comes. Last time, what question they asked? Which of the following is not done when you're doing active management of third stage of labor? And the choices were control cord traction and oxytocin, uterine massage, and bimanual compression. And what did you answer last time in INICET? Bimanual compression is not done because it's very painful. You'll do a gentle uterine massage. INICET again has proved, please remember, uterine massage has to be done. Well, this question is better read with this smiley here, okay? Please do uterine massage, guys. I hope you are convinced now. The number of places I've been trying to tell you, you go to any hospital, you go to any labor room, in front of the labor room, the protocol is given that you do control cord traction and you give oxytocin and you do uterine massage. What is not very important in the active management of third stage of labor? What is that? Early cord clamping or delayed cord clamping. Either one of them can be done. Yes, what we do in our country, we do delayed cord clamping so that our children get that extra 1 gram of hemoglobin. That's fine. But that is not the most important part. That is the least important part of the active management of third stage of labor. So uterine massage is done. Phew, that is out of my system now. So I'll tell you the answer. Remember, 30-year-old woman having PPH, uterine massage has not worked, then you go for the next step. And that first surgical step of management is the balloon tamponade or the Bakri balloon. 500 ml. 500 ml of saline is injected, is infused into the balloon, and the balloon will give a compression to the uterine muscle and that will stop the bleeding. That is a Bakri balloon. You can do uterine devascularization and you can do the uterine artery ligation, then the ovarian artery ligation, and then the internal iliac artery ligation. And if nothing works, you have to go ahead and do the hysterectomy also. Remember the principle of internal iliac artery ligation, hot shot MCQ again. You are trying to reduce the flow, not to stop the flow of the internal iliac artery. And which artery you are ligating? The anterior division, not the posterior division. Right, guys? So let's move on. And wait, I want to see what you guys are asking me here. Okay. Which of the following is not a marker of the ovarian reserve? Yes, ovarian reserve is the capacity of a woman to conceive, and you know that young women conceive easily, old women conceive with difficulty. You know that, isn't it? Then why am I making a big song and dance about this information? All of us know it. Even the guy who is selling vegetables outside your house will know that young women conceive easily, old women conceive with difficulty. But I want to see these parameters of a woman's conception, whether it's easy or not. Why? Because there are a lot of young women who are not conceiving. So when women who are young not conceiving, why? Because the reserve is poor. So you can check the reserve by FSH values, AMH values. You can check by the ovarian size. You can also check it by the number of antral follicles in the ovary. Yes, those are the good tests. Now, which are the tests which are not used, which is not a marker? So AMH is 2 to 6 nanograms per ml. Yes. Then antral follicle count, it should be at least 6 to 7 antral follicles per ovary. And the exam question was, what is a less antral follicle count? So anything less than equal to 3 per ovary. Antral follicle count, it is done on the ultrasonography on the early 3-4 days of the periods. That's when on the ultrasound you will see 6 to 7 antral follicles per ovary. Now, if they are less than equal to 3 per ovary, less than 4 also is given in your many other sources. Less than 4 actually means less than equal to 3. not to get confused. Okay, 6 to 7 per ovary. So this is also good test. Early follicular phase FSH. Yes, if the FSH is high, that is telling that the high FSH means that the ovaries are not making enough estrogen. So the feedback to the brain of estrogen is less. So the FSH is increasing. That's essentially an old woman around 40 to 50 will have a high FSH. But if a young woman is having high FSH, bad news, bad result. Okay. Early follicular phase estradiol is not used. So yes, all of these three are used and this is not used. So that's your answer. D is the answer to this question. By the way, we also use the early follicular phase estradiol. That tells us a high estradiol is bad news. Yes. How does that work? Quickly, I'll tell you. If the estradiol is high in the initial part, answer to your question is D, end of discussion. But yes, being an IVF surgeon, let me tell you, we regularly do the estimation of estradiol also when we're working up. If the estradiol is high in the first few days of the menstrual cycle, 1, 2, 3, 4 days of the menstrual cycle, that means the FSH, the basal FSH is high, a high FSH in the previous few days, the days before the periods. In the previous few days, the FSH was high and it started recruiting a few follicles, and the estradiol is more than what you expect in the first few days. Because the basal FSH is high in the first few days, the estradiol is already high. Estradiol should be high when? The estradiol should be high like this at the 14th day. Because it is high, that will cause the LH surge, and that slowly causes the proliferation of the endometrium. So on the 14th day, this estrogen is the highest. But if it is high here, that means there is a recruitment of follicles a little earlier in the previous cycle. Why? Because the basal FSH was high. Extra bit of information for you guys. Let's move on to the next one. A 30-year-old woman presents with intermenstrual bleeding. Pap smear reveals atypical glandular cells. What is the next step? So many times in your pap smear reports, you see something like atypical squamous cells of unknown significance. Ask us. So yes, we are not worried about it too much, but we don't ignore it. So what we do generally, we'll do a more frequent pap smear. We do a frequent pap smear, that is once in a year we do. Generally, pap smear is done once in 3 years. After 30 years, we do once in 5 years with the core test. That is basics. Now what happens if it is ascus and there's nothing else given? Then we do frequent pap smear. But the question is somewhat different here. The question is intermenstrual bleeding. She is a symptomatic patient. Then when it is symptomatic, you don't do screening test. Remember this. Symptomatic patient don't do screening test. That's why whenever I have taught you post-coital bleeding, please do a colposcopic biopsy. Post-coital bleeding, a pap smear is a screening test and it is sensitive only 48% to 62%. That's why post-coital bleeding, we always do a colposcopic biopsy. We gynecologists, what you get answers here and there. In so many of you students keep telling me pap smear. Arey bhai, you want to do a pap smear? Do. That is not the best test. It is not half as sensitive as the other tests. So the best test for post-coital bleeding is a colposcopic biopsy. Similarly, if the patient is symptomatic with atypical glandular cells, you will have to do a colposcopy with endocervical and endometrial sampling. No half big measures. All right, you will definitely not rely only on a pap smear because she's symptomatic. Once she gets symptomatic, you will anyway have to do a more better test, and that is a colposcopic biopsy. Right, guys? So you got this one also right, I'm sure. The next one is a 35-year-old lady who's had irregular bleeding and transvaginal sonography shows a thickened endometrium. What is the next step? Another hot shot. I'm so happy with this question. Irregular bleeding. They've written 35, and I've told you everywhere in the live classes and also in the app which we've recorded about the abnormal bleeding. Any woman with irregular bleeding, find out what is wrong. And how do you know what is wrong? By getting into the uterus and taking a scrape. Yes, you have to do a curette. You go inside and take a scrape of the endometrium. Now, how can you take an endometrium in the OPD itself? In the OPD, you can do a very easy Pipelle biopsy. So, in the OPD, you can do a Pipelle biopsy, painless, without any anesthesia. You can do this easily. How can you do it? Even better. Pipelle is around 80 to 90% sensitive. But you can go to the OT under anesthesia. You can do a DNC, 95 to 99% sensitive. Or you are still better, you have a good instrument known as the hysteroscopy. So when you do a hysteroscopy, that is 100% sensitive in picking up if there is something wrong in this patient. So yes, always say endometrial sampling. How you do the sampling? I've given it to you once again. Never say I'll give progesterones or I will give I'll do a hysterectomy. If this was written as 45, if it was the choice, you guys would have said do a hysterectomy. Arey bhai, gynae does not do only hysterectomies. Okay, maybe you're right. Outside this room, maybe you do only hysterectomies, only cesarean. But yes, I've been teaching you and I should teach you the right things. And we do hysterectomies only when it is required. That is what is standard teaching and standard practice in my hospital at least. I work in St. Stephen Hospital, and that's a place where still managing patients the way they have to be managed. We are not in any hurry to do cesareans and hysterectomies for every patient who walks in. So please remember, never say hysterectomy first. Always find out the reason of the abnormal bleeding. So that's the answer, endometrial sampling. Which of the following are the signs of imminent eclampsia? You know the stages of hypertension, gestational hypertension. If there is proteinuria, we say it is pre-eclamptic toxemia or simply called pre-eclampsia now. Pre-eclampsia is the best term. And then with hypertension, proteinuria, we call it preeclampsia. Now, if the person throws a convulsion, a generalized tonic-clonic convulsion, then it becomes an eclampsia. Now, when a woman has had an eclampsia, what is the next thing? She's going to get hypoxic, the baby is going to die, and eventually the mother is going to die. So, eclampsia is the worst case scenario. So, do max self, do IV labetalol, but deliver her. Delivery is the best management of eclampsia. That's the basic theory. Now, we are smart and we should be monitoring such patients before they throw eclampsia. We should prevent it. So, hypertension, start the drugs. Hypertension with proteinuria, admit and start more drugs. Hypertension with proteinuria, keep her under a strict vigilance. And now I see the BP is 170 by 120, more than 110 diastolic. I'm worried. It is not getting controlled. Headache, nausea, vomiting, blurring of vision, exaggerated knee jerks, reduced output, and epigastric pain. Why epigastric pain? Gas, huh? No, man. Epigastric pain is because of subcapsular liver hematoma, stretching of the liver capsule. So, yes, all of this is the sign of imminent eclampsia. Yes, so answer to this is all of the above. I'm 100% sure all of the above would not be the choice. It would have been some variation of this information. All of the above, none of the above, two of the above. Like these choices don't come in the exam. If it has come, then I'm surprised, but I'm sure this would have not been the method of asking. So, I don't know. I'll see your questions. Viral pedal edema, pedal edema was given there. So pedal edema is not a method of saying that the patient has gone into preeclampsia. Also, edema is not the criteria. Proteinuria is always there. Edema can be there in normal pregnancy also, isn't it? You know that. So see, all above is not mentioned. Look, Darshini, I'm so happy you said that. You've just justified what I said. There is no exam. So that's why when you have these so many sources where you read all of the above, none of the above, I immediately tell you, please, that is not a proper recall. So even if some Q banks are writing all of the above, none of the above, that makes no sense. So this will not come in the exam. I'm very sure of it. So yeah, the first thing I've joined this organization, the first thing I've done is I've checked the Q bank to remove all these none of the above and all of the above kind of choices. All right, guys. So yes, this of course there must have been more, symptoms. What are you guys telling me? Anything else? Any one of those is not a choice. See, again, it is option maintained. A B C D, A B C D, A B B C D C. Yes, correct. That's how it would have come. I'm very sure. Chalo, good. You have just justified what I told you. Let's move on. In a case of uterine inversion, the shock is mainly due to, yes, the uterus has got inverted because it was a placental attachment here. See here, there's a placental attachment here. And what you've done, you've been in a hurry. You pull the cord like this and the uterus inverts. You know what? There was a very bad question. I don't know whether it was a bad recall. June 22, they asked a question. A woman has been delivered by an intern, and after the placental delivery, the patient goes into shock. I mean, it's assumed that interns are going to yank on the cord and pull it out. Guys, you interns are reading so well. You're reading regularly. All our students who have done MBBS, they do internship, they read so much and then get into PG. So interns know this, that you don't have to yank on the cord. Even the students who are coming from outside, those done the foreign medical graduates, they're also sitting for all the live classes. So nobody is stupid to just go and yank it. So if they had said it is cord has been delivered, I mean the woman has been delivered by an untrained person or in a village, I would have been happier. Anyway, forget the type of question. If you pull the cord, you should be always doing it gently. Gently tug on the cord and a counter traction. This is how you do the plasma delivery. So when you're doing this plasma delivery, the cord gets a little longer. Yes, that's a sign. The plasma separates, fresh bleeding, that's a sign. And now the plasma totally separates and the uterus gets hard. So these are the three signs of delivery of that the plasma is separating. And the best sign is the uterus becoming a little hard. The uterus becoming a little hard, a suprapubic bulge you feel, a suprapubic hard mass. That is the best sign of separation of placenta. But if somebody holds and yanks the cord very fast, especially with a fundal implantation, see here, this placenta is going to pull out the uterus like this. So that is what is ultimately going to look something like this. The placenta attached here and the cord has come out. So that is what is known as a inversion. See, uterus has inverted. It causes severe pain. Yes, severe pain. Neurogenic shock can kill. But remember, always, bleeding is torrential and the death is mostly because of the hemorrhagic shock. So that's always, we always have been taught that hemorrhagic shock can kill and the pain, the neurogenic shock can kill. But the more common cause is the bleeding. It can cause severe bleeding, this inversion. So please go ahead and don't say the neurogenic shock, always say the blood loss is the more common cause. Right, guys? So a cervix showing punctate hemorrhage. By the way, how do you reposit this? Yes. Remember, when you're pushing the uterus back inside with the fist of your hand, first you have to relax the uterus. Look, the uterus was like this, it has got inverted like this. When you're pushing the uterus back, that will go back only when it is soft. So you have to first relax the uterus, push the uterus back inside, now contract the uterus. All right. So you relax the uterus by turbitalin, do a manual reposition with your fist. When it goes back inside, now you have to contract the uterus with oxytocin. And the next question, I know you're going to type and ask me whether the placenta is removed first or in the end. Look, we've always removed the placenta and then done it. But theoretically, good answer, correct answer is push the uterus back inside with the placenta if it is still intact. If the placenta is intact, don't try to remove it because the uterus is inverted and it will bleed more. So yes, ideally push it back inside. Once the uterus is reposited, you are giving oxytocin to contract it, and then with your hand you remove the placenta if it is still attached. So remove the placenta in the end. That is the right technical answer. Okay, what we do in the labor room is many other things, and we'll talk about that some other place. Okay, let's move on. So question number 9, a cervix shows punctate hemorrhages. Strawberry cervix, characteristics of which infection? Guys, strawberry cervix, I mean, there is always, I've told you, the chapter on vaginitis. I've given you in all my places where I've taught you, and wherever the online issues online classes I've taken, offline I've taken, I've given you the comparison of all these three together. The vaginitis, because of bacterial vaginosis, trichomoniasis and candidiasis, all three together in one sheet so that you mug it up properly. And bacterial vaginosis is the one which is always coming. This time they asked you about trichomoniasis. Strawberry cervix or strawberry vagina, both are strawberry color. All right, please, strawberry type, red macules. So it is trichomonas, that is the answer. And the strawberry cervix, strawberry vagina, it is because there is intense inflammation because of trichomoniasis. It causes inflammation of the vagina. We call it colpitis. And then it makes red macules. So we say colpitis macularis. So this is seen not only on the vagina, it is seen on the cervix also. If the vagina is showing you strawberry, the cervix won't show you mulberry or some other fruit, isn't it? No, this has become a problem. Chadwick sign is for which part of the body? Vulva, vagina, cervix. And everybody says, no, it is only for the vagina. Arey bhai, Chadwick sign is for the cervix, classically mentioned in your Williams. Obviously, if the cervix is bluish, that is Chadwick sign. The vagina also will be bluish. It will not be yellowish, isn't it? So strawberry vagina, strawberry cervix in trichomoniasis. Chadwick sign, bluish discoloration of the cervix and bluish discoloration of the vagina. Less that. All right. So not to get too confused about such basics. Okay. Colpitis macularis and the treatment. Remember, bacterial vaginosis and trichomoniasis. Both of these, it is because of alkaline pH. Both of these, the syndrome is almost the same, and both of these are treated by metronidazole. But in a case of trichomoniasis, you must treat the man along with the woman, because trichomoniasis has a 70% chance of transmission with just one intercourse. Yes, HIV is, some people say that it is less than 2% or less than 1%, or some people say one act of intercourse chance of transmission. But trichomoniasis is 70% chance with one act of intercourse that will transmit to the man. So yes, treat the woman, treat the man also. Bacterial vaginosis does not require the treatment of the man. Just the woman need to be treated. Right, guys? Anything else? Yes. Which of the following instrument is not typically used during a cesarean section? This also came as a, I think they gave you a list of 6-7 instruments, and you had to pick up which one are used and which is not used. You had to give a combination type of an answer. Yes, but I'm sure you got it, because you interns, Doyne's retractor is your best friend, isn't it? You hold the Doyne's and you're retracting the bladder and you're hanging for dear life on the pubic symphysis, isn't it? After the first cesarean, you have no interest in the cesarean anymore. You're hanging for dear life, and two gynecologists are operating and they're having a big chat while they're closing. Once the baby is out, we take time to close and we catch up on the gossip, isn't it? So that time, the Doyne's retractor, you know very well, is used. The Alice forceps, tissue forceps, can be used to holding the rectus sheath, and most of the times the uterine angle we are using the Alice forceps. But the technical instrument, the best instrument to hold the uterine angles is the green Armitage, the GAT, green Armitage forceps. All right. Sim speculum is not used. Sim speculum is to examine the woman in the OPD. It is not used for the cesarean section. So yes, Alice is used, Doyne's is used, green Armitage is used. I'll just show you a video. Yeah, see that is the application of the green Armitage. You see, it's got this flat serrated ends, and when you apply, see, we are applying on the anterior and the posterior wall, but we are applying on the angle. See, that is the angle of the uterus where we have cut. This is the abdominal incision, the uterine. See, I have applied here. When I'm applying it there, this is the application of the green Armitage on the angle of the uterus, of the uterine incision. That is to hold the angle and also to stop the bleeding from the uterine artery. Green Armitage. It's a very important instrument, ideal instrument, not the Alice. Yes, mostly we are having Alice forces, because when you open the abdomen, you have to hold the rectus sheath with the Alice, isn't it? So that same Alice we use it. So it's become a habit to use the Alice. It is available. Green Armitage is there on the table. Any cesarean section instruments, the green Armitage will be there. Now this is the other one. Which is this instrument? Yes, I should have shown it in a video like that, but yes, I was standing on this side and I was operating here. So between my fingers, see, I'm going to do the incision. But yes, you must understand that when you're doing this, once more, yes, when you're doing this, that was your Doyne's retractor. Let's see, can you see this here? The Doyne's retractor. This is the retractor which is to retract the bladder and allow us to do the incision. So you interns have been our best friends. I hope you all become, some of you become gynecologists and come and work with me. It'll be fun to work with you guys. All the best, guys, and I hope you've done a very good exam. Get the best seats possible in AIMS, PGI, or my college, JIPMA. Thank you, guys. All the best for the next one.